Hello everyone. Welcome to Med-Surg Mentor. Hope you're doing good. First of all, let me thank all my subscribers for your wonderful support. Please let me know your valuable suggestions. All my presentations are based on current Kerala University of Health Sciences syllabus. If you would like me to do any specific videos from medical surgical nursing, please let me know. I'll be more than happy to include those in the upcoming videos. Alright, let's begin. Last week, we have seen the part 1, which mainly explains about dilated cardiomyopathy. I can give the link in the description box. Today, we will discuss in detail regarding the other two types of cardiomyopathy, that is hypertrophic and restrictive cardiomyopathies. First of all, let's see what is hypertrophic cardiomyopathy. It is a condition in which the heart muscle becomes abnormally thick. The thickened heart muscle can make it harder for the heart to pump blood. In this picture, you can see that the ventricular walls are abnormally thick, including the interventricular septum. Pathological changes in hypertrophic cardiomyopathy. Main cause of hypertrophic cardiomyopathy is genetic factors. Due to this, the heart muscle tissue becomes abnormally thick and rigid. Thus, the chambers become narrow and elongated. As a result, there is an increase in resistance to pump blood out of the heart. Gradually, the heart is unable to relax and fill, which is leading to heart failure and other complications. Let's move on to the types of hypertrophic cardiomyopathy. There are mainly two types, that is obstructive and non-obstructive hypertrophic cardiomyopathy. This classification is based on the extent of the pathological changes. Obstructive hypertrophic cardiomyopathy occurs when the thicker ventricular walls block blood flow out of the heart. But if there is no significant blocking of the blood flow, the condition is called non-obstructive hypertrophic cardiomyopathy. Clinical features of hypertrophic cardiomyopathy are dyspnea, angina, palpitations, fatigue, syncope, pulmonary congestion, S2 split and heart murmurs. Complications of hypertrophic cardiomyopathy are heart failure, sudden cardiac death, mitral valve problems, atrial fibrillation, dilated cardiomyopathy, and arrhythmias. Common pharmacological management of hypertrophic cardiomyopathy are beta blockers like atenolol, antiarrhythmics like amiodarone, calcium channel blockers like diltiazem, anticoagulant therapy, and antibiotic prophylaxis. Next is non-pharmacological management of hypertrophic cardiomyopathy. They are septal myectomy, septal ablation, surgically implanted devices like implantable cardioverter defibrillator and pacemaker, and cardiac transplantation. Let's see each one in detail. First one is septal myectomy. It's an open heart surgery. In this procedure, a part of the thickened septum that's bulging into the left ventricle is removed. This improves blood flow all over the body. And the second procedure is alcohol septal ablation. In this procedure, ethanol is injected through a tube into the small artery that supplies blood to the area of the heart muscle thickened by the hypertrophic cardiomyopathy. The alcohol causes the cells to die. Thus, the thickened tissue shrinks to a more normal size. Third procedure is surgically implanted devices like implantable cardioverter defibrillator and pacemaker. These devices helps to monitor the heartbeat and maintains a normal heartbeat. Fourth procedure is heart transplantation. In this procedure, the deceased heart is replaced with a healthy donor heart. Common nursing management of patients with hypertrophic cardiomyopathy are assess hemodynamic parameters, obtain BP monitoring hourly, assess heart and lung sounds, ensure supplemental oxygen, promote adequate rest, administer prophylactic heparin therapy, monitor serum potassium, and watch for complications. So we have finished the second category of cardiomyopathy, that is hypertrophic cardiomyopathy. And now let's move on to the third category, that is restrictive cardiomyopathy. At first, let's see the definition. Restrictive cardiomyopathy is a condition where the chambers of the heart become stiff over time. Thus, the heart is restricted from stretching and filling with blood properly. Common causes of restrictive cardiomyopathy are amyloidosis, glycogen storage disease, sarcoidosis, radiation, scleroderma, and hemochromatosis. Let's see the pathophysiological changes in restrictive cardiomyopathy. In this condition, the chambers of the heart become stiff over time. Though the heart is able to squeeze well, it is not able to relax between beats normally. This makes it hard for the heart to fill with blood. As a result, the blood backs up into the circulatory system. This can cause fluid to build up in the body, including the lungs, which leads to many other clinical features. It also increases the pressure inside the ventricles and the atria, thus it becomes enlarged. Eventually, the disease makes the heart unable to pump blood out of the body as it normally would. And finally, it leads to heart failure. Common clinical features of restrictive cardiomyopathy are shortness of breath, fatigue, peripheral edema, weakness and lightheadedness, cough, weight gain, and abnormal heart rhythms. Common pharmacological managements of restrictive cardiomyopathy are diuretics, corticosteroids, anticoagulants, positive inotropes, antibiotic therapy, beta blockers, angiotensin converting enzyme inhibitors, oxygen therapy, and antiarrhythmic drugs. Surgical management of restrictive cardiomyopathy. The common procedures are valvuloplasty, myectomy, cardiomyoplasty, ventricular assist devices, total artificial heart like Jarvik 7, and heart transplantation. Let's see each one in detail. First one is valvuloplasty. It's the surgical correction of thick and stiff valves which allows normal blood flow through the heart. Second one is myectomy. It's the excision of the septal tissue in the left ventricular outflow tract, which decreases the amount of obstruction and thus results in the clinical improvement. Third procedure is cardiomyoplasty. It's an alternative to transplantation. The procedure involves the use of autologous latissimus dorsi muscle graft, which is wrapped around the ventricles by pericardial attachment. The muscle graft is then stimulated by cardiomyostimulator. The resultant muscle graft contractions provide support for the ventricular function. Fourth one is ventricular assist devices. These are devices used to maintain the cardiac output for a relatively short period. Fifth one is total artificial heart. It's a pump that is surgically installed to provide circulation and to replace the diseased or damaged ventricles. It is commonly used in patients who are waiting for heart transplantation. Sixth management is heart transplantation. It is replacing the deceased heart with healthy donor heart. And there are mainly two types of heart transplantation. They are orthotopic transplantation and heterotopic transplantation. Common complications of restrictive cardiomyopathy are congestive heart failure, cerebrovascular accident from blood clots, valvular stenosis, myocardial damage, aneurysms, and arrhythmias. Prevention of cardiomyopathy. Common lifestyle modification for prevention of cardiomyopathy are: quit smoking, avoid alcohol, maintain ideal body weight, manage stress, treat underlying disease conditions, eat healthy diet, and stay active. Today, I have explained regarding hypertrophic and restrictive cardiomyopathy, its etiology, pathological changes, clinical features, and management. Hope this video was informative. See you next week with a different topic from medical surgical nursing. Thank you so much for watching and have a great day.